Good morning. This is the House Appropriations Committee. It is Tuesday morning, January 14th, 2025. And we'll continue some of our learning and catching up and reviewing what's happening in the world today. And this morning, we're going to start with the world of Medicaid. And we have from JFO, Noel Langwell, who is the Principal Fiscal Analyst at the Joint Fiscal Office. And he's going to start us on some Medicaid 101. You have some documents there, and they'll be up on our committee page for those that want to take a look. This will not be the only time we're going to talk about Medicaid, but this is the first time we're talking about Medicaid. So welcome, Nolan. Do you need us to introduce ourselves? Would that be a good idea?
Yeah, why not?
Why don't we do that? We need to practice anyway.
A couple of new folks that
Okay,
haven't met.
so we'll start with Dave Yacob.
Good morning, Dave Iacoboni, Lamoille, Washington District. Glad to be here.
Good morning, John Kosensko, Essex Caledonian District.
Mike Nigro, Bennington, northern part of Powell.
Tom Stevens, Washington Chittenden District, and from Waterbury.
Morning, Jim Harrison from 11 Chittenden, Mendon, Killington, and Pittsfield.
Test.
Let's see if John can.
He's advisor of most of the council. I'm Robin Scheid from Middlebury.
Tiff Lumley from Burlington.
Trevor Squirrel, Underhill and Jericho.
Wayne LaRush, Franklin 5, got Franklin, Berkshire, Richford, and Spin.
Harvey.
Lynn Dickinson, St. Town.
And Mike Borwicki is Putney and Dutterson.
Okay, great. For the record, I'm Nolan Langwell. I'm with the Joint Fiscal Office. I've worked with most of you at some point, but there's several new faces. So thank you for that introduction. And bear with me, this is my first testimony for the year, so I often fumble the first couple times up. But today we're going to talk about Medicaid. There it is. Oh, that's the wrong one. Sorry. Option. I need all right. The purpose of this is try to be a kind of a high level Medicaid 101, start introducing some of the principles and ideas of things that you're going to be hearing about in budget adjustment and with the budget, terms like local commitment and FMAP. So the idea behind this is to try to start giving you some foundation. What I always tell people who have not done this for the first time, and same joke I tell every year, you're required to laugh if you heard it, but if you don't get Medicaid the first time, it's not you. And this stuff is really complicated. If you don't get it the second time, it's also still not you. I mean, this stuff is really complicated. However, the third time, if you don't get it, it's still not you. Medicaid is very, very complicated. Let's laugh at that. I gotta work on my delivery. I'll work on my delivery.
Just make it slow.
Okay, good. Medicaid is complicated. So I'm happy to sit down with anybody as we get into it. If you want to have a little one-on-one, like one-on-ones with me to sort of better understand specific pieces, I'm happy to sit down with any of you to help you understand. I use a lot of data in here. I have to put this sort of disclaimer in. We try to use the most up-to-date data. However, some of the data is a little outdated. One of the things I like to use is the Vermont Household Expenditure Report. The Vermont Household Health Insurance Survey, and that hasn't been done in several years. I think I saw it in budget adjustment. Very happy to see that. Another thing that I often use is the Vermont Expenditure Analysis, which is put up at the Green Mountain Care Board. That hasn't been updated since 2022, and I've talked to them about it. There's always a 2-year lag anyway, but they haven't done it in a couple of years because of some data issues, and that hopefully will be remedied. But as a result, a lot of my data is 20, 21, 22, during pandemic, pre-pandemic. So it may not perfectly reflect where we're at today, but I'll point that out. But the underlying premise is still the same, because I'm really talking about percentages and growth and other stuff. But we get into like the numbers and expenditures for the state that we have, those are all up to date. But I'm talking about how many people are uninsured, or what's the total spend by all Vermonters on commercial insurance. That data is a little bit outdated. But when we come in and we say, this is how much we're spending on Medicaid right now, that we know, because that's us, and we get that from DEVA. So I'm gonna start with a very high level, like health insurance, because that's what Medicaid technically is. It's health insurance. And what is Medicaid? We'll get into a little bit of Medicaid finance, and then I'll talk about global commitment to start. So this is the high level context. I'll move a little fast. Stop me if I'm going too fast. But this is sort of the insurance picture. Again, this is from 2021. It actually probably hasn't changed a whole lot, but you can see, 49% of Vermonters were under private insurance. 24% of folks are on Medicaid, 21 is on Medicare. So you can see about 45% of Vermonters are on some public insurance. And I'll get into the difference between Medicare and Medicaid. You really just need to know Medicaid. Medicare is federal, Medicaid is state. You're going to have AHS in here and DEVA, the Department of Vermont Health Access, who oversees Medicaid in here later in this week. The Medicaid numbers have gone up and down because of the pandemic. I won't get into the details of why that was, but I just wanted to give you a sense. We're talking about in this room, when we talk about DEVA, we're talking about that part of the pie, the Medicaid piece. Other points for other conversations and bills that come in here, we may start talking about commercial insurance or subsidies, but we're not really getting too much into that today. But I just want to lay that out as part of the context. This is also a chart that's also a little outdated, but the underlying point is still the same. I like to point this out, is if you look, this is on one side, it starts at 2008 and it goes to 2021. And you can see that in 2008, 60% of Vermonters had private insurance and about 45% of Vermonters were on some form of government coverage, state or federal, Medicare or Medicaid. And you can see that by 2021, that kind of flipped a little bit, where you had 45% of Vermonters covered by some kind of coverage. And you can see that, Medicaid, which is just the blue on the second one, was 16% in 2008 and 24% in 21. So you can see that the amount of people that are covered by Medicare or Medicaid in general is increasing, and the amount of folks that are on private insurance has kind of been decreasing. And there's lots of reasons for that.
Yes. Jim.
Is that indicative of the average income in Vermont being, going down, or
I think
for other reasons
I think it's a whole slew of reasons. One of those is aging population. But I think there's a lot of different reasons. Our coverage has gotten more generous, the Affordable Care Act. There's a lot of particular things that have sort of played into that. And we don't know what that trend has been doing. We had all the redeterminations during the pandemic, and none of that's counted in here. So I would like to know what that looks like today. Has that changed a little bit? But I just want to point out that had kind of been the trend. And that stuff has budget implications. And that's why you're going to see when Medicaid comes in every year, it's like, wow, our Medicaid spending has gone up. Our Medicaid spending has gone up. Our Medicaid spending has gone up. So I just want to flag.
Yeah, one of the reasons was the ACA, which in 2008 or 2009
Yep.
expanded eligibility.
Yep. And we've had, and the state has also done some things.
And the
as well.
other interesting piece here is that the smaller the private insurance becomes, the lower the percentage. There's fewer and fewer people who will be paying the cost shift if the Medicaid, Medicare don't pay the full cost for care.
Yeah, we
That
won't
has
get
an
it.
impact on our insurance premium.
Yeah, well, it all affects the pools, the
Yeah.
insurance pools
Yeah.
too, But yes, you're exactly correct.
A couple more questions here, Rep. Stevens.
And following up to Representative Dickinson's question, then does it not have an impact on hospital budgets?
Absolutely.
Because Medicaid and TRICARE which we're not talking about military insurance, but they're notoriously low reimbursement rates. So
They affect all systems. Hospitals, to your point, are the largest provider in the system, so it affects them the most.
So we only have data through 21. What's the reason for the lag? I understand last fiscal year, whatever.
So like I said, so it has to do with it's a combination of, it was at the Green Mountain Care Board, had a combination of personnel changes and some vendor issues, and it was like a whole slew of stuff. And when they explained it to me, I was like, I get it, that stinks, I'm sorry to hear that. But they're working really hard to kind of get it up to speed and get me the data that they, so they're well aware of it and they're trying to work on it. It was stuff that, to defend them a little bit, it was a bit beyond their control, unfortunately. So hopefully that will be remedied soon, within several months.
One more question, Rep. Finley. Have you looked at how this compares, this breakdown compares with other states?
Oh. Don't have it. I looked at this more like that's a really interesting fact we need to pay attention to.
Yeah.
Didn't really break down to the comparison of how this relates to other states. Other than the fact that we know that we're one of the oldest states on average in the country, but that's one of many factors that contribute to it. So Medicaid and Medicare are not the same. And I put this big yellow thing because many of us, when you first get into it, you'll conflate Medicaid and Medicare. And just not even realize you do it because you've said Medicare many more times in your life because of your aging parents or yourself or whatever, right? So, but they are not the same. And so here's the biggest difference. So Medicaid is a state and federal program. Medicare is federal only. Medicaid is for low income. It's for children and adults and who are 65 or older and blind, disabled. Medicare is all incomes, but 65 and older. And there's also this like carve out for people with end stage renal disease. And then, or if you're under 65 with certain disabilities. But the biggest piece so this gets into two pieces. One is how it's funded and what the eligibility is. So with Medicaid, we control Medicaid. We don't control the eligibility. We have some control over eligibility, but not a lot. And I'll get into that. But this is the piece that affects the state budget. There's nothing in Medicare in the state budget. It's all Medicaid. And I'll get into how the state and federal partnership and matches work in a moment. Medicaid was created in 1965. And the other point I want to point out is that each state sort of designs and operates its own program within the federal guidelines. And so the joke there, not a joke, but is if you've seen one Medicaid program, well, then you've seen one Medicaid program. And the joke behind that, or not a joke, is that Medicaid in New York is different than Medicaid in Vermont, which is different than Medicaid in Tennessee or Mississippi or California. We all have our own, there's basic underlying of things we have to cover, but every state has a different federal match. Every state has done different things in how they expand their eligibility, how they run it, and then particularly how they pay. You know, when we get into global commitment, we are the only state that runs our Medicaid program the way that we run it. So every state has these agreements called waivers, which I'll get into, or most states have them. And that sort of dictates how they do it. And every state does it differently. So if you've seen one Medicaid program, you've seen one Medicaid program. Nationwide, there's 80 million people who are on Medicaid or CHIP. CHIP is the Children's Health Insurance Program. It is not a Medicaid program under the federal, it's a separate program. However, we administer it through our Vermont Medicaid. You'll hear this thing, actually, I won't get ahead of myself. There's approximately 197,000 Vermonters who receive some form of Medicaid and CHIP. Now, this is very clear. You'll often hear, oh, 25% of Vermonters are on Medicaid. This is a piece that I like to really highlight, is that you have folks that have Medicaid as their primary source of insurance, and you have folks that have it as their partial. So the folks that have it as their primary are generally below income or folks who get in because of a disability. And that's approximately 151,000 Vermonters, or about 23%. So when you hear that, okay, about a quarter of Vermonters have Medicaid as their primary. But then we have our partial and supplemental. That's our, that would be folks who are receiving subsidies to the exchange. Well, their primary source of insurance is Blue Cross Blue Shield or MVP, but they're getting a subsidy to the state, which is funded through our Medicaid program. Or we have folks that are who have VFARM, which is a supplemental prescription drug program for folks on Medicare. Well, Medicare is their primary, but Medicaid also helps supplement their donut hole and other folks. So when you hear people say, well, a third of Vermonters are on Medicaid, it's not true. A third of Vermonters have I don't want to say have some kind of relationship with Medicaid, but 23%, or could be as much as 25%, about a quarter of Vermonters have Medicaid as their primary. So that's a piece that I like to really differentiate. So, because language matters. So for Medicaid, there's two pieces. You have your eligibility, and that's who is covered. To qualify, you have to be a Vermont resident, you have to be a US citizen, permanent resident, or non-citizen with lawful presence. Your financial situation would need to be categorized as low income or very low income and be one of the following: pregnant, responsible for an 18-year-old guardian or younger, blind, have a disability, or a family caretaker of someone with disability for 65 years in age and older. So we have our eligibility, who is covered, then we have our benefits, what is covered. And under Medicaid, we have states are required to provide some via our mandatory benefits. These are the things that we're supposed to, and then we have our optional. And so this is a list of, just to give you a sense, and you don't have to memorize them now. Yes.
Representative.
Just a clarification, low income or very low income is based on the poverty
Yes, poverty level.
or area median income.
Usually it's the FPL, federal poverty level. And I have a FPL chart at the end of this presentation, but I'll also provide a hard copy for you to put on the wall so David Sheets can come in and say that it's not architecturally accurate. But nonetheless, it's always helpful to have, those, or you can put them in your copy, which is, you're going to be hearing about FPL a lot, but it's based on federal poverty level.
So I'm just pointing out that we're going to be talking about some facets of this budget on the federal poverty level, but we're going to be talking about some of them based on area
That's
median
right.
income,
That's right.
and they don't necessarily, they correlate sort of
Maybe.
sometimes.
Right. So low in, we need to define our terms. That becomes really important because low and moderate income means something in one area and something different in another area. So that's a good point.
Yep.
Rep Dickinson.
Yeah, we do have, I don't know if it's a waiver or whatever, but back in the 90s, we included up to 300% of poverty. That was the federal poverty level. We was expanded.
That was, so I know we did the 90s, but I know under Catamount Health, which was a subsidy, we offered up to 300%. And now we have subsidies. We still do subsidies, state subsidies up to 300% on the exchange. And then, childcare has a different FPL like this. So
Yeah.
and one of the things that's confusing, just as an aside, is that you have a lot of benefit programs across DCF, DIVA, DMH, and they all have different eligibility factors. So, and you're going to hear different FPL, different requirements. Some are based on your disability, your situation, your housing status, your FPL. So right now, today, we're just talking about Medicaid. And even within Medicaid, we have different populations and there are different doors in which they become eligible. Your age, your disability, your income, your pregnancy status. There's all these different pieces and it gets very weedy very fast. I'm going to try to avoid that today, but yes, both your points are very well taken. This is a list of things that as a provider of Medicaid, we have to provide these services: inpatient, outpatient, nursing facilities, home health, physician services, lab, et cetera. Those are the stuff that any state that provides it has to provide these services. Then we have our optional prescription drugs, dental, PT, glasses, Tyro, et cetera. These are all, and there's other stuff that we don't offer that are also that we can offer. And this is when I say that you see one Medicaid program, you see more Medicaid programs. Vermont's pretty generous compared to a lot of other states, what we offer. So these other services are services that we offered. The bulk of the spending tends to be in the mandatory services.
In the mandatory?
In the mandatory, because that's like your inpatient, your outpatient, right? In the past, when we've been looking at different ways to save money, people will say, well, how much would it cost to cut this and cut that? It's really, some of them really do not cost a whole lot.
Dr. Kosensky.
Just a quick question. Do these services differ per state as well?
Yeah, so the mandatory, every state has the mandatory.
Right.
But the optional, some states, yeah, like we cover Cairo, some states might not. We have dental, some states might not, right? That's why when I say every state is, it's,
You've seen one Medicaid program, you've seen one Medicaid.
this is one of those factors. So now that, okay, I still have some time.
Thank you.
So now we're gonna get into the money, and I apologize if I'm moving fast. And again, I can come back or I can work with anybody individually, but I want to get into the weeds here a little bit of what we're here about today. We're about the money in this community. Here's another number that I wish I could update, but I can't. This is 2020. This is the total healthcare spending in Vermont. It was 6.37 billion. I suspect it's probably 8 billion or more today. This is given that we're in 2025 now, but we don't have that data at the moment. But I think the thing that will stay the same is you can see total spending on healthcare across all different payers across the state Medicaid accounted for 27% at the time, and that number has pretty much stayed consistent through time. It'll be in that 25 to 30% range when we do get it. It's so just give you a sense of how Medicaid spending is, relative to other payers within the state. So it has state budget contracts, state budget implications. So this is an up-to-date number, right? So in 24, Medicaid accounted for 27% of the total state budget. So you can see that I've sort of added a little line. This is a line from, I think, one of Catherine's and Emily's presentations that they did to the full legislature. And you can see total human services was $3 billion, but Medicaid is 2.3 billion of that, just to give you a sense. So it is Medicaid alone is the second highest spend after your education, your K-12 spending, right? Just to give you a sense of the context and the breadth of Medicaid within the state budget. So total appropriation to the state, again, this is context. In 24, the total appropriation was $8.7 billion. 2.3 billion of that was Medicaid, which was 27% of the state appropriation. So 27% of our state appropriation, and this is state and federal dollars combined, was Medicaid spending. So you can see it's a big part of the dollar in the state. And then a lot of that's federal dollars, and we'll start getting into the weeds of the federal dollars. So total federal funds were $3.7 billion, which is 36% of the state budget. So 36% of our state budget are federal funds. Medicaid accounted for 40% of the federal dollars that are appropriated to the state, just to give you a sense of the total spend and how that goes. So overall, our Medicaid spending was 2.3 billion gross.
Define gross, if you would.
Define gross. Oh, define gross.
Define gross.
Define gross.
Supposed to match.
It's, I was gonna make a bad joke, but I won't.
Yeah, okay.
This is
That's
important.
how you mean gross.
No, and this is a term you'll hear a lot. It's total spending. So that'd be state funds, federal funds, special funds, the total dollar appropriated, total dollar spent in the budget.
All funds.
All funds, thank you, better way to put it. So total funds or all funds is the gross. So we spent $2.3 billion gross. Yes.
I don't know how many different programs this affects, but doesn't the state claw back a certain amount of these funds through like provider taxes?
Yes, but that gets in the revenue. I wouldn't call it clawback. I would.
Well, yeah, no.
And I'll actually get a little, so I'm going to put a pin in that.
Okay, all right.
But if I don't get there, remind me, but I'm going to put a pin in that because what I'm trying to get to is the match and the state dollar. That's how we get some of our state matches for the federal pieces. So Medicaid is a combination of state and federal funds. Our federal government matches, we have this thing called FMAP. It stands for Federal Medical Assistance Percentage. You're going to hear this a lot. Most, but not all of our federal funds for the state's Medicaid programs are FMAP. And I say that because there's some stuff in like health departments that are grants. But for the most part, most of our federal dollars that we get for the Medicaid are through FMAP. This federal match ranges between 50 to 90% depending on the program and or expenditure. That's just within our state. So for instance, most of our FMAP is, and I'll get this the second, it's like a 40, 60, 40, next slide will show you the exact difference. But then our CHIP program is more closer to 70-30. Actually, and our admin is about 50-50. So we have different matches for different programs, or some of our exchange subsidies for the premium assistance, some of those folks are 90-10. So across the programs, there's different federal matches, and I'll get to that in this next slide, but the vast majority of them are of the regular match, which I'll get to in the next slide. So FMAP, and this came up the other day when Adam was sitting here and he said, well, how is FMAP calculated? It's calculated based on a 3-year average of per capita state personal income compared to the national average. And that's the high level description. It gets the weedier, and I don't even know the weeds of that, but that's kind of their basic premise. So that when Adam was saying, well, when our income is down across the board, our FMAP is up. So when we see that our FMAP And that's over a 3-year average. So our FMAP has been kind of going up a little bit. And we're like, yay, our FMAP is working for us. But that just means that Vermonters' income is not increasing. So it's like double-edged sword, right? I threw this in again, when we talked about every Medicaid program is different. I want you to just sort of see how we compare to other states. So no state can receive less than 50% or more than 83%. So there's a bunch of states that are at 50%, and those are your high income states, your Connecticut, California, New York, New Jersey, Washington, Massachusetts. Those are the states that have a much higher per capita income, and they're kind of hitting up against the max. And then you have states that have low per capita income, the lowest being Mississippi. Their FMAP is 76.9%. West Virginia is 74%. So Vermont, we're at 59.01%. That means the federal government is picking up 59%, and the state's picking up 41%. And just to so you can see how we compare to other New England states, Connecticut, New Hampshire, Massachusetts are 50, Rhode Island at 57.5, we're at 59, and Maine's at 61. And then I have a little arrow that just kind of show you who's went up and who went down. And again, this is just our regular FMAP. So with this right here shows you just sort of some of the different FMAPs we have, right? So we have our regular FMAP, and that's the current one for 26. So that we're doing the 26 budget. This is the FMAP that you will be working with. It's 58.81. So that's the state share. That is the federal share, which means the state share is 41.2%. A good way to think about that is for every dollar, every dollar we put into it, we're getting $2.43 in federal match. Flip side is.
And is that, but you said that's the gross, so isn't that the state and the federal?
Oh, sorry, you're right. That's the gross. Sorry, thank you. For every $1, what I meant to say, for every $1 we put in, we're getting $2.43 in service.
So this federal government is giving us $1.43.
Correct. Yes. Thank you for the.
We just need that little middle column.
No, yeah. Yes, $1, the federal government's giving $1.43, and we're getting $2.43 worth of service. It is a flip side. When we cut a state dollar, we're losing $2.43 in services. So it cuts both ways. So when you hear about, we're going to cut this, well, it hits the providers harder than it hits us. So I just wanted to sort of share that. Again, then we have our enhanced matches. So we have our CHIP program, the Children's Health Insurance. That's 71.17 to 28. So for every dollar spent, we're getting $3.47 in service, or $2.47 in federal. And then we have our childless new adult. We have these things called Medicaid eligibility groups. And again, I'm not going to get too much into this, but there's different eligibility groups doors that people enter. This is one of those groups. And these are Affordable Care Act subsidy folks. So for these folks, it's about 41,000 people who get this subsidy under this particular bucket, we'll call them. And for these folks, we're getting a 90-10 match.
So if I could just ask you quickly, childless adults, and it says new adults. So these are younger people? Is there an age that's associated?
No, there isn't. We just called them new adults because it was a new program. At the time that it was named, that's how it was done, because we had folks on so during the Affordable Care Act, we had VHAP, which was the program we had Medicaid, we had VHAP, which was an expansion program, and then we had Catamount Health, which was a public-private partnership program. And when the Affordable Care Act went away, the eligibility sort of changed. So some of the folks that were on VHAP went into regular Medicaid, and some went into the exchange, and same for Catamount Health. Some of those folks that were Catamount Health went into the exchange, and some of those folks just went to private insurance. But they were new adults in our naming mechanisms. So I didn't name it. I was here, but I didn't name it. So they were new adults, newly covered adults, however you want to call it. But that's sort of how it's been named. And this is more of a behind the curtain title. But the point I want to make is that there's 41,000 folks for who are getting subsidies to the exchange. They're on a private plan. They're getting state subsidy on top of the federal subsidy. And the state is collecting a 90-10 match for this particular.
They don't have children, hence the child.
These folks do not have children, yes. I know, it gets confusing really quick. what this is meant to show you is the ups and downs of the FMAP, right? Because we talked about how FMAP goes up, FMAP goes down. And so on the years that it's gray, this is state share. On the years that it's gray, the state share increased, which means that the FMAP decreased. And when the state share increases, that means we have to pay more for the same service. When the FMAP goes up, so for instance, our FMAP went up this year by like almost 1% or half, I don't remember exactly, but it went up this year. So to provide the same level of service, it actually costs us a little bit less to provide the same level of service. When the FMAP goes up, it costs us more to provide the same level of service. That doesn't even include your increase. So since the FMAP went up and our costs went down, it helped offset some of our increases this year, so you still see an increase in our Medicaid spending, even though we had a more favorable FMAP. It would have been worse if we didn't have that, right? And this sort of shows the history. I'll answer your question in a second. I want to finish this point. This just sort of shows the history of the ups and downs of the FMAP. But what I also pointed out here is there's been several times throughout Vermont history here where we have received these sort of temporary federal enhanced FMAP. So for one, like according during the ARA, which is the American Recovery and whatever, that was we got extra because that was during the downturn. And so we got extra federal assistance over a 3.5-year period to help the states do this stuff. During the Affordable Care Act, we had a little extra bump. And then obviously during the pandemic, we also got an additional, we had 6.2% FMAP bump. So those are periods of time where we got additional federal help because that was what's one way when states are suffering through a pandemic or whatever, that the federal government can provide some fiscal relief to the state to help provide these services.
And so Rep. LaRouche and then Rep. Dickinson.
So how much lag is there in calculation of FMAP? Is it years behind or how?
It's based on the 3-year average per capita of the previous year.
Rolling average going.
Yeah.
Rep. Dickinson.
Yeah, I'm trying to, when the FMAP goes up, our income basically has gone down on that 3-year now.
Yep.
And if our FMAP goes down, we're making more money. The incomes go up.
Correct.
Okay. So the gray is the FMAP decreasing.
So that's the
we're more
state share.
progress.
So that's the state share. So this is where it gets confusing.
Okay.
More of like an
Yeah, I'm
estimate.
losing it, yeah.
Yeah. But I wanted, because I in this one I did the state share. People often conflate the FMAP and really it should be called an SMAP, right? Because it's state share, but we call it FMAP, but really the FMAP is the federal share.
Right.
But I did it here, the state share, because
State share.
this is the number that you really care about.
So this is the reverse of what you just said. So
Correct.
when it goes, it's decreased.
So when it's
The
gray,
FMAP has gone up.
when it's gray, it means our state share is increasing.
So that means we have a lower income.
When our state share increases,
The FMAP goes, the Fed
When our-
goes down, ours goes up.
when our state share increases, it means our federal share is decreasing,
Yes. and the
which means
federal-
that our income is going up.
Yes. So if
I
the
don't
state
need to-
share goes up, that means our increase is going up.
Yes,
Our income is going up.
correct. I'm sorry.
If the state share goes down, like in these plain white ones,
Yeah.
that means that our income is also going down.
Yeah, I mean, the easier way to think about it is when our income is worse, the federal government is giving us more.
Right. Okay.
But I apologize if
I
that's
know it's an
confusing.
inverse,
Yeah.
trying to figure it out.
This personal incomes track state shares.
Right, yes, personal income track state share, good.
I apologize for me if I made that more confusing than need to be. But I think everybody kind of gets the point now. I hope. And then global commitment. I'm not going to get into the weeds on global commitment, but this is a term you're going to hear a lot. And so I wanted to just sort of make sure that you understand what it is on a high level. So global commitment is short for global commitment to health. It's an agreement. You're going to hear it's our waiver. So what a waiver is, it's an agreement. So the global commitment is the name of the agreement between the state of Vermont and the Federal Centers for Medicare and Medicaid Services. You'll hear this called CMS, which is federal government. And that's how we administer the majority of our Medicaid program. It's known as a Section 1115 demonstration project, often referred to as a waiver. And these waivers exist to encourage state innovation and provide states with flexibility in designing and how they improve their Medicaid programs. Waivers, 1115 demonstration projects, whatever you call them, have to be budget neutral to the federal government. So two things. One is some states have multiple waivers for specific programs. Okay, we're gonna do a waiver for folks and try to get them out of nursing homes, or we're gonna have a waiver for folks with mental health, and they might be just a small piece. They might have multiple. We used to have multiple. We used to have choices for care, and that's part of global commitment. We may be the only state that operates our whole Medicaid program through a giant waiver. So, and again, that's an agreement, and I'll get into a little bit more details. The other thing I want to point out is when we say budget neutral, what does that mean, right? So we've had this waiver now, or global commitment for, I forget, a long time. I think it was 3 terms ago from Representative Iacoboni here. Probably going on 15, 16 years. And we renegotiate them every 3 to 5 years. And what it looked like then is very different than what it looks like now. But the idea behind it is that budget neutral in terms of we won't spend more than what we would have in the absence of a waiver. Now, of course, we don't know what that'll be because we've had a waiver for so long. We don't know what our spending would be outside of the waiver. So that turns into a negotiation between the state and the federal government about what do we think our waiver would be in the absence of a waiver. And so, but in short, the basic premise of it is that it has to be budget neutral to the federal government. The federal government doesn't want to spend more on us than they would have in the absence of the waiver. But it gives us the flexibility to innovate, to do things that we would not have been allowed to do under a normal waiver. And I'll get into more weeds after I answer your question.
Is this kind of like a block grant with a master's degree?
When we first, I believe the first waiver was under the George W. Bush. And at the time, he was pushing block grants. And I think one of the reasons that they approved this was because of the closest they'd come to a block grant. But it's not really a block grant because they're not giving us a lump of money and going, okay, we don't, this is more of an agreement, and it's not a lump of money, but it's an agreement on how much max amount of money that they'll spend. Now, obviously, we want to build as much cushion in there as we can. In the past, we've had a lot of cushion, and we've had some years where we have very little cushion. It depends on the administration and what they allow us to do. But it's not a block grant, but it's the closest anybody had come to one.
So, because the block grant, if I heard you correctly, the block grant is saying, here's $100, you can spend it however you want, as opposed to what this sounds like is you can spend up to this and develop whatever programs, savings,
Within guidelines.
within those guidelines, right? So
And if we go over that amount, we're on the hook.
over the FMAP.
We go, no, over above the cap for what global commitment agreement, the budget. So the budget neutrality is cap, right? There's how much we can spend over the 5-year period. We go over that, it's 100% state dollar. So we've never gone over, we've come close.
So when we see this list of the list of non-waivered or whatever this things that we do with this, we're making these work. That the idea is that the programs are developed, that it's going to come under that commitment number.
Yes.
We'll see that in the budget and budget adjustment. Maybe you could give an example of a demonstration project that comes under this waiver. What have we done? What are some things that we've done?
There's a whole list of them.
Okay, there you go. Thank you.
Our state subsidies, V-Farm, choices for care. So for folks who don't know what these are, our state subsidies for the exchange. So right now we offer under folks who are under certain incomes on the federal exchange for health insurance, they get a federal subsidy. We enhance that subsidy by giving them a little bit more, but we are able to get federal match by doing that. We have our V-Farm program. So again, we are providing folks lower income, folks who are on Medicare, help them covering their donut hole for the prescription drugs. If we did not have this program or we didn't have the waiver, we wouldn't be able to do that, or it would be 100% state dollar. Choices for Care, again, this is a program that is really meant to help create independence for folks and get them out of nursing homes. We are able to spend state dollars to help this. If we didn't, it would be all state dollars without match. You get the drift. Then we have these things called global commitment investments. And
1 second, Rep. Yakavoni has a question.
Do we have much headroom now between our, and what we're actually spending?
I believe so, because I think at the moment, the current agreement is from 22 to 27, 2022, 27. So where we're at or how we look at an annual, you'd have to ask the AHS. But we've come close in the past, but we've never gone over. And that's actually where you want to be, right? You want to maximize it. You don't want to leave anything on the table, but you also don't want to go over. So kind of being close is a safe but scary place to be. But where are we at now? We're in the middle of our waiver, so I don't know about that. I
I
will,
think I think we're starting to run late. Okay, and then I want to give people like 3 minutes to have a quick break.
Okay.
So, and then we're going to have you back anyway, so.
Okay.
You have 60 seconds to say whatever last thing you need to say, and then we'll take a 3-minute break and then we'll get started with them.
the last thing I'll say then is, other than the fact that I've really enjoyed my time here, is that there's a thing called investments, and you're going to hear about the investments. And this is another example of things that we are able, so the idea behind when we've, gosh, can I use 30 seconds? When we first did it, it was very much a managed care-like model. And the way the managed care organizations work is they help pay for a population, and any profits that they make can be profits, or any savings or profits. For us, we try to do it in a way that we manage people's population or their health, and we are achieving savings. Those savings can be reinvested into these things called investments. Investments are things that definitely would not have been able to pay for in the absence of the federal assistance. We have about 69 investments worth $120 million. That's $120 million on things that we're getting match on that we wouldn't have otherwise. I won't get into the details of that, but they have to fit within certain guidelines, and we have to get permission to do it. So when you hear about things called investments, when Diva is in here, that's what they're talking about. It's a payment for a service provided under global commitment that we would not have been able to do in the absence of it, and nobody other states are doing this. I will leave it at that. I'm happy to come back. I'm sure at some point you may want me to come back and do this again and kind of nail it in a little bit harder.
We will have you back, Noel. Thank you very much. Appreciate that. I think